So, trophoblastic diseases are an important cause of miscarriage in the first quarter of the pregnancy. There are rare neoplasias. They are rare neoplasias originating from the parts of the placenta and from parts of the placenta, and they produce ACG, which is one of the most useful markers in oncology. Moreover, they are highly chemosensitive. You must recognize it because if you do not treat the patient, she will die. Classification. We have benign tumors that are partial vesicular mole and complete vesicular mole. We have transitional tumor, which can be an invasive mole in which the vesicular mole invades the myometrium and becomes aggressive. And we can have malignant tumors like choriocarcinomas and intermediate trophoblastic tumor. Vesicular mole. Incidence, it's around 1 over 1000. In Asia, it's more frequent. And the risk increases with maternal age. And genetic origin of partial moles. Two spermatozoa fertilize one egg. The result is a triploid conceptus with 69 chromosomes. PHM are dyspermic, which PHM are dyspermic and may be 69XXX, 69XXY, or 69XYXY. Genetic origin of complete moles. One spermatozoon fertilizes one egg, but, for unknown reasons, maternal chromosomes are lost. Hence, the paternal chromosomes double up. The appearance of the zygote is normal because it has a normal karyotype, but the origin is only from the father. This is a complete mole that in the end destroys the placenta completely. Microsatellite polymorphisms. They are useful to differentiate between partial and complete moles early in pregnancy. From a pathological point of view, it's very difficult to distinguish them, in fact. Diagnosis is done by clinical examination, ultrasound, histology, and beta-HCG. Symptoms are: in 58% of cases we have vaginal bleeding, 2% of cases we have anemia from the abundant bleeding, 44% of cases we have uterine size greater than expected for the gestational age because the uterus is full of vesicles. And in 2% of cases we have hyperemesis because vomit is stimulated by ECG that interacts with a special area in the brain. In a normal miscarriage, usually the patient does not vomit a lot because ECG is low. And so the symptoms are, as said, vaginal bleeding, anemia from the abundant bleeding, uterine size greater than expected, and hyperemesis. Complications are preeclampsia, hyperthyroidism, respiratory failure, cardiorespiratory complications, and uterine perforations. Nowadays, complications are rare because the diagnosis is made early on in the pregnancy. In the past, the diagnosis was made in the second quarter of the pregnancy, and these complications were more common. Ultrasound. In the normal pregnancy, you can see the embryo, the amniotic fluid, the placenta, and gestational sac. In the partial mole, you can see the embryo and the amniotic fluid, but the placenta is filled with these black holes, vesicles. Sometimes it's easy to distinguish a normal pregnancy from a molar disease, as in this case, on the right. The most important difference is the fact that the complete mole evolves into a tumor in 10% of cases, so you must diagnose it as soon as possible. Treatment: histological and cytological examination of the uterine cavity. 90% of patients don't need further treatment. You must follow up the patient with serial weekly ECG checks from 21 days following the molar evacuation until their return to normal for 3 consecutive weeks. Then you do triploid stop follow-up, HM until 6 months after evacuation, and for 6 months after ECG normalization or evacuation. If normal ECG, more than 60 days after evacuation, no, if nothing. Normal is okay, nothing. If beta ECG is positive after 6 months, you must suspect the malignant evolution of the mole. The gestational trophoblastic tumor, that is the persistent trophoblastic activity, is defined as a disease state after pregnancy with clinical evidence with positive beta ECG without histological exam. Histological exam is not performed because the biopsy may cause life-threatening hemorrhage in these patients. Staging is done by the FIGO system. Stage 1, disease limited to the uterus. Stage 2, tumor with metastasis to the genital apparatus. Stage 3, tumor with lung metastasis. Stage 4, other metastatic sites. Prognostic score. We have a low risk if less than 6, high risk if more than 6. Take into account these parameters, which are age, preceding pregnancy, an intervention before pregnancy, ECG, increased diameter, the a previous CT, number of metastasis, sites of metastasis. So we have age, previous pregnancy, intervention before pregnancy, interventions before pregnancies, ECG, diameter, number of metastases, previous CT, and sites of metastasis. The prognostic score determines the treatment approach. Low-risk patients, for low-risk patients, so less than 6, use methotrexate and folinic acid. It should be repeated twice a week until ECG results normal for 6 weeks. In high-risk patients, we do an aggressive treatment. You perform an elective polychemotherapy according to the scheme EMA-CO, etoposide, methotrexate, actinomycin, cyclophosphamide, and vincristine. According to the stage, survival ranges between 70% and 90%. Poor prognostic factors are brain metastasis, which allow 80% of survival, liver metastasis, 30% survival, liver and brain metastasis, 10% survival. Patients die because of resistance to chemotherapy or because of early complications that may be life-threatening in 10% of cases. Acute respiratory failure if metastasis in the lungs, hemorrhage if metastasis in the liver, intracranial hypertension if metastasis in the brain, and so. And this occurs because this tumor is very chemosensitive, and the necrosis is so significant that it may lead to acute chronic dysfunction, to acute organ dysfunction. Late complications may be secondary tumors due to chemotherapy. There is an increased incidence of myeloid leukemia within the first 5 years, mainly due to etoposide. Another late complication is early menopause because chemotherapy is gonadotoxic. During chemotherapy, you should assess the response to the treatment by checking the level of beta-ECG. Choriocarcinoma. It can originate after any pregnancy outcome. at term delivery, abortion, extrauterine pregnancy, and is more frequent after complete mole, 3%. You should suspect it if beta HCG is present 6 months after pregnancy without another ongoing pregnancy. If a young patient complains about pain and bleeding a long time after the end of the pregnancy, you should suspect a choriocarcinoma. In a young woman, it's possible to find multiple metastatic lesions of unknown origin. A simple dosage of beta-HCG can make the diagnosis. In 30% of the cases, the symptoms are due to metastasis, dyspnea, hemoptysis, neurological signs, hemoperitoneum, persistent metrorrhagia after a pregnancy. Placental-side trophoblastic tumor. It accounts for 1% of trophoblastic tumors. It originates from the intermediate trophoblasts. It derives from a pregnancy, molar abortion term. There is intracellular production of HPL and low level of beta-HCG. Differently from other trophoblastic tumors, it's poorly chemosensitive. The therapy of choice is hysterectomy. So therapy of choice is hysterectomy. In case of metastasis, you should use polychemotherapy with IMACO, which is etoposide, methotrexate, actinomycin, cyclophosphamide, and vincristine, or etoposide, methotrexate, actinomycin, EP. And you should follow up the patient for a long time.